All right, now we're going to continue on with chapter 17, intrapartum, or during labor, fetal surveillance. In other words, we're watching. Okay, so we do this because we want to keep track of what's going on with this baby, this fetus during pregnancy. So that's when they go to the office and we get the fetal heart tones and maybe we do ultrasounds and we're watching the heart rate then. We want to see if there's anything that can result in hypoxia. We do this by two ways, fetal monitoring by two ways. Intermittent auscultation with palpation of uterine activity, and this is pretty low tech. It's not as invasive, possibly. And then we have electronic fetal monitoring, either external or internal. So during labor, the fetus can be deprived of oxygen just because of the contractions and so forth. And so how the baby reacts to this, we need to know about. And so there may be compression of the maternal vessels, there may be compressions of the cord, and there may be some compressions of the head, which is kind of normal if it's coming down head first, obviously. So intermittent auscultation is when we are listening to the fetal heart sounds at periodic intervals, okay, maybe every hour or whatever, okay. They're easy to use, they're less expensive, they're less invasive than electronic, okay. This is, however, this kind of monitoring is more difficult to do on a woman who is obese. And it does not give you a permanent record other than what you document in your chart, but there's no tracing. Whereas electronic fetal monitoring, either external or internal, which we will talk about, you can actually have a tracing on paper and you can also store that information in a computer database. So here are some devices that can be used to check do the intermittent auscultation. Now on the left-hand side, the A is the typical Doppler that we use to detect fetal heart tones. Now the little wand that you see there, lots of times the top of the wand or the head is much wider. That really doesn't, it can be used that way. B is one that cannot be heard by anybody but the examiner. And so maybe once the little flat piece there at the end, you put the ultrasound jelly on and then you listen, and then sometimes you can pass those ear pieces to the mama or the daddy. And then the C, this is a very old device, but it's still used. It's called a fetoscope, and I've got a picture of it here in just a minute. And you listen, it's like a stethoscope, but it's for babies. And then, the other picture, you may have seen these before. We have the toco transducer and the other for the uterine contractions, and you see the lady hooked up here in the bottom picture. Okay. The top picture is the use of the fetoscope. You see that thing goes around the top of your head. You rest your forehead on it, and then you put the earpieces in, and then you try to find the fetal heart, and you listen. And then the bottom picture, again, is a more modern, frequently used Doppler to hear and you can turn it on audibly so mom and daddy and whoever can hear it. Okay. This is something that's relatively new, and I've not seen this used, but I know some of the other larger facilities. This is actually uses Bluetooth to pick up heart tones and contractions, and women can often be up walking around with this. But again, I've not seen it used, but it's out there. Okay, so the advantages of fetal heart monitoring is it gives more data about the fetus than just auscultation. We just hear it, but it doesn't really tell us too much. We can achieve, again, a paper record, a computer record, or both sometimes. Continuous electronic fetal monitoring shows how the baby is responding before, during, and after contractions, which is difficult to do if you're just doing your listening. And one nurse can actually look at two laboring women on a screen at maybe the central nurse's station to see what's going on. So it doesn't require one-to-one always. The limitations are because it's, she has to stay hooked up to a machine. If it's external, we can take them off and let her get up and go to the bathroom, but then you got to put it back on. And you can see here maternal position changes or an active baby can often make you have to move things around, and constant equipment adjustment, get the best tracing. Some women think it's uncomfortable, and some people think it's really high tech, but honestly, it's really not that much, I don't think. So this is the paper that we can record things on. And I think I misspoke the other day. I said between the big lines is 5 minutes. It's one. Duh. So you can see the upper part of the paper is used to record the fetal heart rate. Okay. And it's vertical in beats per minute. Okay. And then the bottom part is to record uterine activity vertically scaled in millimeters of mercury, or HH or mmHg. So the top is for the fetal heart rate. As you can see, it goes down to 30 up to 240, and then the intensity of the labor contractions and the timing and the duration can be graphed on this paper from your monitor. So this is just another view of it. The increments between the vertical lines represent 1 minute. Fetal heart tracing is displayed in the upper pane and the uterine activity in the lower. And you see we got some contractions here. We've got a nice resting tone where it goes back down to the baseline. Here's just another one. This is a very reassuring strip. Okay, we've got fetal accelerations, which is good. Okay, and pretty good contraction patterns. So this is just a picture of her putting all the stuff on. Okay. Okay, so internal fetal monitoring is not done very much unless it's really, really indicated. And it gives us a really, really more accurate picture of what's going on. So the requirements is, and this is important to remember for internal fetal monitoring, the woman has to have ruptured membranes. The membranes or the water has to have broken, okay? And then she has to be dilated at least 2 centimeters. Sometimes even some docs won't do it till she's a little more, okay? There's a slightly increased risk for infection because it's inserted through the vagina, okay? The fetal scalp electrode, that's a little electrode that's actually put under the scalp of the baby's head, and it gives us a heart tracing. And then the intrauterine pressure catheter can be used to measure uterine activity, intensity, contractions. So that oftentimes this may be done if you have that meconium stained amniotic fluid and they're really concerned about the health of the baby, et cetera, et cetera. So there's indications for it. This is not done routinely. It's usually external because you can see it's very invasive. Okay, so the fetal scalp electrode, that's exactly what it is. It goes to the scalp for your internal fetal heart monitor, and then your intrauterine pressure catheter goes right along the wall of the uterus wall and the muscle and can feel contractions, and it produces a tracing on your monitor. This is what the little electrode looks like at the top picture. I don't know if you can see it on the very, very end. There's looks like a little wire sticking out. That's like a little corkscrew, and they just take it and just barely clip it out of the skin. The baby does not feel it, doesn't hurt the baby. And then the bottom picture is your intrauterine pressure catheter. These are only inserted by physicians. I don't think midwives are allowed to do this. Okay, so fetal heart rate patterns we need to talk about. We have the baseline, okay? 110 to 160 is what's normal. So every baby has their own, okay? The variability is those little waves or fluctuations on the baseline is called variability. And so we do it for at least 2 cycles per minute or greater. And so we have 4 categories. We have absent, we have minimal, we have moderate, and we have marked. We want to see moderate variability, okay? Absence could be that the baby is very asleep, over-medicated, we don't know. That's not a good sign. Minimal is not as good. Lots of times minimal may happen after you give mama fentanyl or something like that. So here's just some examples. Again, I don't necessarily expect you to remember these verbatim. As you can see the top, there's absent variability. There's something there, but it's so quiet. Okay. I can't really tell what the heart rate is. And then you've got your minimal, then you've got your moderate, which is average, which is what we'd like to see. We have variability from 6 to 25 beats per minute. And then marked that's a little bit much. We would rather not see that. Okay. So tachycardia is above 160, and that usually often indicates a maternal infection. Remember that. Tachycardia in the baby, in the infant, in the fetus, greater than 160, sustained, as you see here, great for 10 minutes or more, is often indicative of maternal infection, and that's not uncommon with premature rupture of membranes. In other words, her water broke 2 weeks ago and nothing's happened. That automatically, of course, that there's an opening there, so we want to keep track of that. Bradycardia, less than 110 for 10 minutes or more, and for a baby to go that low and stay that low, it makes everybody nuts, and where people are moving, getting things done. Sometimes there's changes just related to the uterine contractions, and sometimes there's changes that are not associated with uterine contractions. Accelerations, which is what we've talked about before, are a good indicator of fetal well-being. Good sign. Okay. Accelerations, as you see here, associated with fetal movement is reassuring. Okay. Sometimes we can get some accelerations with a vaginal exam, sometimes during contractions, mild cord compression, and then oftentimes with a breech presentation. So here's a strip, and I think we've seen this one before, but you can see we have some accelerations, and this is a very reassuring strip, very reassuring. Early decelerations are associated with fetal head compression, and that head is going to be compressed no matter what because it's coming through the birth canal. So they can have like the baroreceptors in the autonomic nervous system kick in, and they can have some early decelerations, a little slowing, okay? It is not necessarily a bad sign, okay? The return to the baseline by the end of the contraction is reassuring, okay? Oftentimes, moving mom around has no effect, and they often mirror the image of the contraction. So let's look at that. Oh, here you go. It's okay to be early for dinner, but we don't want lates. We do not want late decelerations. Okay. So here's some early decelerations, as you can see. So we have the peak of the contraction, they start to go down. So see, they mirror when the contractions are peaking. You see that? But it comes back up to the baseline pretty quickly. And again, this is probably head compression. Nothing we can do about it. We just watch it. Late decelerations are often a sign of impaired oxygen exchange. Okay? Begins after the contraction has peaked. Remember, at the peak of the contraction, that muscle is tight and there's not much blood flow. But after the contraction stops, it starts to go down and the blood flow starts to come back. It should get better, but it's starting to go down. And so this is a non-reassuring. It is not a good sign. Late decelerations look a little bit like earlies, but they are shifted to the right. I'll show you. You have to intervene ASAP. Get that mama off her back, get her on her side, give her some oxygen, buy a mask, don't mess around with a cannula, open her IV, give her a bolus of fluids, call for help. Keep an eye on that heart rate. Keep an eye on that heart rate. So here's some late decels. As you see, they are on the right of the peak of the contraction. So you see the heart rate go down as the uterus is relaxing. So this is not a good sign. Okay, the placenta or the cord are being compressed. So if we can get her off her back, the cord compression might be lessened. If her placenta is starting to poop out, then we need to get the baby out. Variable decelerations. Again, the cord could be compressed. Okay, oftentimes the cord compression. If there's a prolapsed cord and it comes out before the head, that's not good. The shape, the degree of fall below the baseline are variable. Sometimes they look like a V, sometimes they look like a U. That's why we call them variable. The rate, fall and rise, is very abrupt. It plummets and then it comes back up. This, again, requires nursing intervention. Sometimes we have to get her up on her knees, do the knee chest position, and get that baby's head up off that cord and take her to the delivery room, get her delivered. So here's some variables, okay? Sometimes they come without contractions. So you can see there's different shapes here. I've got some pictures of one I use. You see where they're falling, and they're just variable. They're very unpredictable. And again, you must intervene. You've got to get her off her side. Maybe you could put her on her knees, chest position, give her some oxygen, get some help. We also notice on our tracings our uterine activity. Okay, So it has 4 components. We've talked about these: the frequency, how often, how long they last, the intensity, and then the resting tone. Does it come back down to the baseline or pretty close to it? So we want to see that. So as you see here, uh, we have this almost looks like a non-stress test, except she's having contractions. But as you can see, there's markers when the baby moved and the heart rate went up. But you see here, the resting tone of the uterus is pretty good. Comes back down to where it had been on that baseline, and that's what we want to see. And then, of course, as they get more intense, the peak of the contraction will go higher on your paper. So your care management of your patient, um, you need to watch the baseline rate, determine that for, get a good tracing for about 5 to 10 minutes. Any variability, if it's absent, minimal, moderate, or marked, any accelerations or decelerations, and anything like that. If anything is abnormal, you must do something to fix that. So supplemental oxygen changes, increasing IV fluids, getting extra help, whatever you need to do to have a good mama and a good baby outcome. Okay, so here's a little acronym to help you remember some of these tracings. We call it VEAL CHOP. So you take the word veal and you spell it out VEAL, and on the other side the CHOP. So if you have variables, look across. That's because of cord compression. The E's are for earlies. We don't care. Head compression. It's nothing we can do about it. Just keep an eye on it. Accelerations are okay, and lates, placental insufficiency, maybe a cord around the neck or something like that. This is a very helpful thing for people I've found that helps them keep track of fetal heart tracings, what they all mean. VEAL CHOP, VCEHAOLP. So there you go. Hope that'll help you. Here's some websites that you might try to see if you want to practice.